good afternoon. My name is Beth Macy. I'm an author and a journalist, and I've covered the opioid crisis since 2012. My two books, Dopesick and Raising Lazarus, illustrate the impacts the crisis has had on people, families, and communities, as well as the ways treatment and harm reduction can save lives and prevent overdose deaths. While the impacts of the overdose crisis are ongoing and devastating, there is hope for treatment and recovery. We have the tools, we've had them for a while now. We need to help individuals with addiction to achieve recovery. Medications for opioid use disorder, I'm old school and sometimes still slip and say MAT, but we're saying MOUD, are FDA-approved treatments for opioid use disorder. Methadone is one of these medications, and it's among the most important tools we have to fight to end the overdose crisis, particularly in an era of fentanyl. Despite having a treatment that saves lives and knowing the impact it can have in turning the tide of the crisis, according to SAMHSA, the vast majority of people with OUD do not receive medication treatment. We have an 87% treatment gap in this country. That means that in the past year, only 13% of folks, and that's 7 million people, have been able to access evidence-based care. Today's panelists are experts on methadone and opioid use disorder from different backgrounds and roles in the methadone treatment system. They'll explain the basics of methadone and shed light on the realities of the methadone treatment system in our country. Our first panelist is Dr. Yngvild Olsen, who serves as the director of the Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration, or SAMHSA. Dr. Olsen has previously served as a medical director of methadone treatment programs and has a long history of working in addiction treatment and also helping with my latest book. Our next panelist is Dr. Edwin Chapman, who has practiced, I think, addiction medicine probably longer than anyone in the country, definitely longer than anyone in the room, in Washington, D.C. for over 40 years, whose experience is vast, and whose work also addresses important racial disparities in treatment access. Next panelist will be Dr. Ruth Potee, who is a family doctor and addiction medicine provider in Western Mass. Dr. Potee also currently serves as the medical director for the Franklin County House of Corrections. Lastly, we have Zach Talbott, who is president of Talbott Legacy Centers in Tennessee, which provide comprehensive substance use treatment throughout the state. He's also the most recent past president of the National Alliance on Medication-Assisted Recovery, an organization founded by and comprised of individuals whose recovery pathways are supported by medications for opioid use disorder. He is a licensed social worker and nationally recognized expert in comprehensive opioid use disorder treatment. Okay, we're going to start with Dr. Olsen. Let's start with you. As a director of the Center for Substance Abuse Treatment at SAMHSA, you're one of the country's leading experts on effective evidence-based treatment for OUD. Could you give us a short overview of methadone as a treatment? What exactly does it do, and how effective is this medication?
Thank you, and good afternoon.
Good afternoon.
All right. Warm them up. So it is so incredibly exciting for me to be here with you all today, partly because of the esteemed panel that I'm here with and what we're going to be talking about. Because as Beth mentioned, so I was, before coming to SAMHSA, I was the medical director for an opioid treatment program in Baltimore City, and really had the pleasure of being part of just the lives of people with opioid use disorder who were treated with methadone. And you know, I'm so glad that you asked this question, because there has been a lot of misinformation and misunderstanding over the years related to what methadone is, what it does, what it doesn't do. And so having this opportunity to kind of talk with you all and hear from the panelists about this issue is just really exciting for me. So in short, and this is not a panel on the pharmacology of methadone, so we're not going to get too detailed, but I do think that it's important to really understand that this is a medication that is FDA approved for the treatment of opioid use disorder. And in order to really understand what methadone does, you have to understand a little bit about what opioid use disorder is. So this is a health condition that for people who develop it really is characterized by just an unbelievable compulsive craving, just this unbelievable drive to like, I gotta keep using, despite incredibly, sometimes very harmful negative consequences. And over the years, I've had a lot of people say to me, like, Dr. Olsen, I wish I could stop, but I can't. And sometimes people have equated that the withdrawal that happens from opioids, that that's really the addiction, that's the opioid use disorder. It's actually not. It's part of it, but it's this just drive of like, oh my God, ongoing cravings, and I just can't keep, I just can't stop. So what methadone does, it is an opioid, it's what's called an opioid agonist. It suppresses the withdrawal that does happen with opioid addiction and opioid use disorder, and it reduces those cravings. So the way I describe it to people, including my patients in the past, is it really stabilizes the part of the brain and the body that is involved in addiction. So I think we're going to get into kind of some of the more myths and misunderstandings, but one of the things I just really want people to understand is that for anyone who takes an opioid, whether it is illicitly manufactured fentanyl, whether it is heroin, whether it is a prescription oxycodone for people who have cancer pain, or other chronic health conditions and pain conditions, if they take enough of an opioid for a long enough period of time, they will also develop withdrawal if they suddenly cut the dose or stop taking it immediately. They may not have an opioid addiction or an opioid use disorder. So we can talk a little bit more about that. I'm happy to take questions kind of at the end, but I really just wanted to make that note that that methadone has a long history of 50 years of use in the U.S. With lots of evidence. There are numerous studies that show that it reduces the risk of opioid-related overdose by over 50%. There's not a whole lot of other medical interventions that actually have that kind of impact on saving lives. And it's not only opioid-related overdose mortality that is reduced, it's all-cause mortality. So with methadone, it really helps save people's lives, and they get their lives back together because of the impacts that it has on those cravings and stabilizing kind of their entire physiology, so that they can now focus on all the other things that they want to be able to accomplish in their lives. So I think with that, back to you.
Gosh, I have seen so many lives saved personally from it, and I've seen lives lost when they've lost their access to it over and over. Dr. Potee, when doing the research for my books, a common argument that I heard from opponents of treatment access is the belief that medications for opioid use disorder, like methadone, oh my gosh, I can't tell you how many times I've heard, it's just treating one drug addiction with another drug, treating one drug for another. Dr. Potee, you're an addiction medicine specialist and methadone provider. What do you say to the many people out here, and I really think it is the number one kind of stigma thing about it. What do you say to them?
Thank you. And I'm also very excited to be here with all of you. I'm going to repeat a little bit of what Dr. Olsen said. Patients who struggle with addiction don't want to have addiction, right? They want to be fixed. If I had a magic wand sitting in my office and I said, you're done, you don't have it anymore, that's really what people want. People just want to be better. They want to be better now. And if that were possible, we would do it. It's just not possible, right? But people who go to quote-unquote detox and just get off everything and think they've landed on the other side all good, I wish it worked. And for those of us that run these programs, detoxes, we acknowledge it actually doesn't work for people who have a fentanyl use disorder or severe opiate use disorder. It works about 5% of the time, maybe, to have sustained recovery. So what I say to people is, methadone is like every other medicine I give to you. There's people in this room, I know I have a lot of young 20-somethings who maybe don't take a single medicine, but there's a lot of us in this room who do take medicine. And whether it's thyroid replacement medicine or insulin or a medicine that relaxes your blood vessels so your blood pressure is better controlled, I'm just giving you something that your body needs, that it used to make, but it's not making anymore, right? That's all I'm doing. It's not substituting another drug for a drug, right? It really isn't. And when I spend the time to tell patients that, and I explain the way it works, that what it's trying to do is restore the dopamine system in your brain that has become so dysregulated from chronic exposure to opiates, right? You stop making dopamine, your dopamine receptors get erased, your dopamine reuptake inhibitors all get kicked out. All of that makes your brain different than other people who don't have opiate use. And when I give you an opiate like methadone that we have been using since the 1960s, it's a miracle drug. That's what I know about methadone. It is, and I'll talk a little bit about it more, but it's the most miraculous molecule that people don't have access to in this country.
You're good. Here.
Or did you want to be able to finish their remarks?
I say go up.
Hi, Representative Tonko, it's an honor to meet you.
It's a big honor to meet you. Thank you for your wonderful works.
Thank you.
Good afternoon, everyone, and this is thrilling to see so much interest in what is a very important issue that addresses quality of life, saving lives, and a whole bit of work in between. So it's my honor to welcome you as one of the co-chairs of the Addiction Treatment and Recovery Caucus. I co-chair that with David Joyce, Representative Joyce, as a co-chair, and then our vice co-chairs, Dean and Chavez Ritter. And I thank everyone that made today's Methadone 101 briefing possible. I will begin with special thanks to Global Health Advocacy Incubator and Libby. The folks have been great. Recently facilitated a visit over to the Fairfax County Addiction Treatment Center. And that was a very important visit for us. And we'll talk about that in a minute. And I do thank our moderator. Thank you, Beth. Thank you for, Beth Macy, I think, has shown so much light on this issue with her two works, Last is Rising and Overdose. Thank you for that excellent work and really drawing our senses to what is a very important public health crisis. And also with the recent update by SAMHSA of the methadone regulations. Dr. Olsen, thank you for part of that leadership, and certainly to all of our panelists that are here today. As we all know, there's no corner in this country, and in fact, we could make it an international crisis, where the whole efforts to respond to overdose are critically important. So it's important that we're having this discussion. Last year in Congress, I think we made a major step as we passed the bill that I've been working on for years, that I authored, the Mainstream Addiction Treatment Bill, that then makes medication for those living with the illness of addiction possible as a treatment. And as we all know, that eliminated the outdated barriers that prevent more people, indeed, from having access to buprenorphine, a life-saving drug for addiction treatment. By passing that law, we're vastly expanding access. In fact, some of the numbers coming from the agency, we're taking 135,000 today as prescribers to a maximum of 1.83 million. To me, that's a whole lot of hope. That's a whole lot of lives saved. And we just have to fully implement that measure. And anyone interested in this issue, call us if you have ideas on how we can expand the outreach and the full implementation. But however, even with that progress, we know that there are deep gaps that remain. This Congress, I have encouraged my colleagues to undertake a comprehensive discussion on how to expand access to treatment, including medications for opioid use disorder, and not just buprenorphine, but also methadone, as we were hearing here early this afternoon. I'm also making certain that those who interact with our criminal justice system, which many times are loved ones, our neighbors, total strangers, end up incarcerated with this disease. So we need to have a clear path for their recovery as well. So I've introduced common sense reentry legislation that would allow states to restart an individual's Medicaid benefits 30 days prior to release. So that all of those programs, wraparound programs of all sorts, including addiction treatment, would be made available because we know the statistics. Within 15 days of release from prison, there's 129% more of a chance of death by overdose. So if we're about saving lives, we best do the reentry bill. And I think it really is a win-win situation. I'm also proud to support the Modernizing Opioid Treatment Access Act, which I believe takes an important step in expanding much-needed access to methadone. This past summer, I toured 2 OTPs and learned firsthand about the current delivery system and where we fall short. So I know that everyone here today recognizes that we can do much better for our community, for our loved ones, our friends suffering with the disease of addiction. I urge all of us to listen, discuss together, and plan how we can best come together and treat this as the illness it is. If we can't approach it with that sense, we're not going to get to where we need to be. So let me leave you with this. The only way to attack a crisis, I believe, is with a measure of boldness. And we need boldness now, big time, urgently. So with that, I want to welcome my colleague, my friend, Don Norcross, who represents Southern Jersey, who has introduced legislation to expand access to methadone. And I believe we're going to be joined by Senator Markey, who may have been delayed in the Senate with votes, but we're hoping he'll be able to join us too. So Don, if you would, please. Thank you, everyone, for being here.
Thank you, Paul. Let's give him a round of applause. Paul, you're doing a wonderful job in a very difficult climate. And forgive me, I am recovering from COVID, and it's something that is played havoc on my voice, so please bear with me. First of all, thank the panel. I was just catching a little bit as you started, and it's fascinating. And here I am. I recently turned 65 years old. And when you talk about the disease of addiction, where we were 30 years ago, 20 years ago, 10 years ago, and where we are today, vastly different areas. Many different developments along the way. But today we're going to talk about something that in many ways hasn't changed for 40 years, and that's methadone. Not the actual drug itself, but the way it's dispensed, and certainly some of the issues that we ran into during the pandemic. So, why am I up here talking about this? I live in the city of Camden, New Jersey, directly across from downtown Philadelphia. A very urbanized area. And I live, for you younger folks, record players were called Victrolas, and I live in the building where they made and invented the first one. It's the old RCA building right there in the corner. And Jersey, a few years back, I hit with one of these blizzards. A Jersey blizzard, 30 inches, everything shuts down. No buses, no police cars, no fire engines. And I'm up on the 5th floor. And out of my window, I can see where the subway exits the ground. And remarkably, in that snowstorm, I saw only footsteps from that subway to the methadone clinic, which is a block away. Now, at the time, I didn't realize what I was seeing. Shortly thereafter, I met with one of the major hospitals in our area, Cooper Health Systems, and spoke to Dr. Batchen, who was the head of addiction medicine. She is now the New Jersey Commissioner of Health. And we started to have a conversation the way methadone has been working. Prior to that, the only way I knew about methadone is when a couple of my dear friends who were in recovery would tell me their story. From, as they say, on the other side of the coin. Each day, having to get up, going through the obvious challenges of withdrawal, but going on methadone, and what I call the cattle call each day, going to feed, while you're trying to put your life back together excuse me, boss, I have to go get my methadone this morning, so I might be a little bit late. It's not one or two people. It's what everybody is doing. And we're asking people that we do recover, that we do become productive members of society. So, long story short, we had a pandemic. And quite frankly, many people were forced in terms of OTPs, to giving out long-term prescriptions. Now, long-term, more than a day, the 30-day rule came into effect, which quite frankly went right in the face of some of the OTPs. If you can never do that, the end of the earth will come. So we started to take a look at this. And I sort of had a conversation with the OTPs on how we can expand this, because whether it's Europe, many of the countries over the way they are dispensed elsewhere. What I found incredibly challenging is, let me understand this, I can go by the Rite Aid and get my script for opiates, but I can't get what I need from my local Rite Aid. Something wasn't clicking. So long story short, we started to put together is how can we modernize, and that's where the conversation that we talked about, modernizing the Opiate Treatment Act. We have about 43 co-sponsors now. It's moving over in the Senate. Very simply to say that appropriate licensed physicians should be able to dispense, to write a prescription, and you should be able to go to the Rite Aid, CVS, wherever it is, pick it up under the guise of a physician. And as I was sitting in the back room, I heard the most miraculous molecule that we can't get. And I said, that's going to be my talking. Because that's what we're talking about. No other medication. When we see the groundbreaking drugs that are coming out for cancer, costing hundreds of thousands of dollars, you can write that script, but you can't write a script for methadone. So we're moving to change this. So after 2 years of negotiations, trying to work through this with the OTPs, I found out, and for those of you who are a little bit older, Linus and Charlie Brown, she holds the football, and each time he goes to kick it, she pulls it back, is what I was running into. And I'm being quite frank. So, Webster defines a cartel, literally, as a combination of independent commercial or enterprises designed to limit competition or fix prices. Now, let me be clear. Not every OTP is part of the cartel that might come to your mind. For-profits, non-for-profits. And this is where it gets very personal to me. Because I heard the statistics, we know that the better access to methadone, the more lives we have saved, period. Now, I live in an urban area that we have 3 of them relatively close. But that doesn't happen across this country. And there is a way here, but the cartel is blocking us. We want to open up, quote, the competition, so that no matter if you're in an area that there might be only one clinic in a state, give people a chance to live. Because that's the difference of what's going on. It takes but a few minutes to have this discussion. And I encourage you and my colleagues back here have a white paper on it to take a look at it. We have many, many sponsors, but the cartel is handing out cash and stopping people from recovering. Now, I just want to say for those who are recovering, God bless you, you've had a chance. We want to give all those that we say goodbye to who didn't have that chance an opportunity to get the methadone. So thank you for being here today. I appreciate what is being talked about. But with this change, and you heard the change to the rule last week that SAMHSA put out, which talks about giving 7 days, 14 days, 28 days worth of methadone, which starts to change the stigma, so I don't have to go every morning. But what it doesn't do it's give better access, and that's what we're trying to do. So Paul, thank you for giving me a few moments here, appreciate it, and thank you for being here.
My pleasure. Thank you, Dr. Miller. Just quickly, my apologies again for interrupting the flow on with the panel. I think Zach Talbott, are you next? So just bear for one more minute, please. I want to acknowledge Representative Beth Macy from the state of Vermont. So she's entire state of Vermont and voice in this process.
Time for mighty.
Very energetic and very hardworking and very interested in this issue. And we thank you for serving on the ATR caucus. And with that, again, we thank you all for being here. My heartfelt thanks to the panel. It is just good to hear all of your voices. Okay.
We'll go to Zach next. And Zach, I know you're a person in long-term recovery, and your perspective is so valuable. You've been a methadone patient yourself, and you now run your own methadone treatment center. What are some of the barriers that people face every day to access treatment, particularly methadone?
Thanks. Well, chiefly it's the lack of access and the communities that don't have OTPs or those that do that are full, often because of draconian state regulations that limit numbers of patients. But for a variety of other reasons as well, because we've siloed medication, methadone in particular, into its own siloed system of programs. And that doesn't mean, I think we have to be very careful as someone who spent 10 years in an opioid treatment program and who is alive because of methadone treatment. I think we have to be careful not to throw the baby out with the bathwater and not unintentionally demonize the good work and the good professionals that are doing good work in opioid treatment programs. But we can have a both and reality. Some of the good things that happened when I was in treatment, and I did happen to stumble into a good treatment center, I didn't know that at the time, it was patient-centered and evidence-based, was that these medications, methadone, and if ever more difficult in the fentanyl area to get folks on buprenorphine, but buprenorphine as well, it keeps people alive. But people like me deserve a chance to thrive as well. And so to make sure that patients have access to the comprehensive array of services, but are not forced into them if they don't need and or don't want them. I think, and so when OTPs do it the right way, and many do, there are bad ones as well, that's what you see. You see people that are stabilized, and as Ruth said, it normalizes the brain. It normalizes a dysfunctional brain. I remember Herman Joseph, one of my mentors, saying that over and over again. And what I encountered is I didn't trade one drug for another. I traded dysfunction for stability, and misery for hope is what I traded. And it normalized, I never felt high on methadone. Now I'm certain someone who's not opioid tolerant can get high, but just the very nature of it, the reason it was approved for opioid use disorder is different than the short-acting opiates of abuse, including short-acting prescription opioids. And so we have to be careful not to demonize the good work that OTPs are doing, because in some ways, when it's done right, it was one of the original integrated care models where people had access to all these different things under one roof. But we've run off the rail at some point, starting to force people into boxes. But patients also deserve options. Patients are not head of cattle, and that's why it would have been, I guess, 2020, the fall of 2020 before the last presidential election. When I was with NAMA Recovery, we worked with Congressman Norcross's office on what is now the MOTAA that's gone through different iterations, because it really espouses a sensible both and approach. And as someone that's in recovery, I can tell you I didn't need to get a week or a month of methadone on day one. I might not be alive if I had, but that's me, and we have to allow clinicians to make those decisions, not regulators, not bureaucrats. And so that's what the MOTAA would do. It's also important to a subset of bad OTPs that we remind that patients are not cattle and that no one owns us, that we are living, breathing people. And I should not have had to drive, even though I was only going once a month in my final days of treatment, I should not have had to drive 2 hours each direction to receive care if there was a board-certified addiction specialist in my community that could have treated me. And so I think it's important that we espouse a both-and approach. We prop up the good that OTPs are doing, but we recognize there's access gaps, and that patients, especially those that are stabilized, deserve other choices. One other thing I'll say that's an access barriers that so often people with opioid use disorder do not, they espouse the same stigma. So I didn't go to enroll in methadone treatment for a long time. I was actually a graduate student in clinical social work, ironically enough, when my addiction spiraled. And I felt that I would be trading the witch for the devil, just like so many others. And so I kept coming back to evidence, and so eventually I went. But it's important to remember, I now tell my staff, remember the 90%. We spend 90% of our time on 10% of patients that have more chronic illnesses that are more difficult to stabilize. And the 90%, most people who are on methadone are in what I call the methadone closet. And you never know. They're on PTA, they're on your church pew on Sunday, they're people like me, but most, and that is the true face of treatment. They're graduate students in clinical social work programs. And I think that's a big barrier because you don't often see the true face of treatment, the success stories, because the fear of stigma is so real. Loss of job, loss of child, this is used against us in custody cases, and so many other things. So that's a loaded question, Beth, but I would say those are some of the big barriers right there. But I believe, if I may plug again, Representative Norcross and Senator Markey, Senator Paul, Representative Bacon, and so many others, the MOTAA, I think, is a big step in the right direction. It's measured, it's sensible, it doesn't throw the baby out with the bathwater, and it puts it back in the hands of the treating clinicians.
Thank you, so well said.
This is the part where I beg the tolerance again of Dr. Chapman. I apologize. You're seeing Washington at its usual flow. You've heard Senator Markey's name mentioned many times over here today, and I had a great opportunity to serve with Senator Markey when he was in the House, and he chaired the Natural Resources Committee when I was on that committee, and I watched his work and how he gets things done. When he believes it's the right thing to do, he will fight that whole effort until he crosses the finish line. So, Senator Markey, it's an honor to be involved with you on this issue. Thank you for honoring the caucus today, the ATR caucus, which I co-chair. We appreciate your great work, and please, the floor is yours. And Dr. Chapman, we're going to you next. So, thank you, Senator Markey, for joining us.
Thank you, Paul, so much, and thank you all for all of the work that you do each and every day. And it's great to be here with my good friend, Paul Tomko, and with all of you, heroes in healthcare who work every single day in order to deal with this plague. So this, for me, I apologize to you. I'm on the Senate side, and I do get my steps in. We're in session, we have roll calls on the Senate floor right now, so I'm just running back and forth, and I extend my apologies to you. It isn't any secret that we're in the midst of a overdose crisis. Does this microphone work? This one works as well? Oh, it does not. In 2021, 2022, 2023, we lost 100,000 people each year to overdose. Millions more are living with opioid use disorder and are unable to get the treatment which they need. One of those treatments is methadone, a gold standard, evidence-based medication that does work. It has been validated in study after study and by expert after expert. The issue is that methadone is so often locked behind laws and regulations that are based on old evidence and outdated understandings of how to treat opioid use disorder. To get prescribed methadone and to get the medication, patients have to go to an opioid treatment program. Most counties don't have an opioid treatment program, but that's the law. You have to go to a place that doesn't exist in your county. That's the law. The drive times or bus rides to these clinics can be long, especially if you live in a rural area. And the clinic hours can be very short. They might close at 4. You don't get off work until 5. You have to get to that clinic that doesn't exist in your county. You might not actually get access to the treatment which you need. And the clinic hours, wind up with, in many times, you having to stand outside, being stigmatized as someone in need of this treatment. Now, the Biden administration is working to improve access to opioid treatment programs by allowing for telehealth flexibilities, increasing the number of health providers that can order methadone, and increasing the number of doses of methadone that patients could take home. But this only helps people who can get to an opioid treatment program. This work is an essential step forward, but a step isn't enough when we're in a race to save lives of thousands of people each week, each month in our country. Here in Congress, we don't see the impact every day when people can't get the care they need. But some of the people in this room do. And I'm proud that we have leaders in Massachusetts like Dr. Potee, who continues to show up each day to treat people living with substance use disorder, stemming the tide of this crisis. But Dr. Potee and the other panelists here today, Mr. Talbott, Dr. Chapman, Dr. Olsen, Beth Macy, you see the consequences when antiquated rules keep people away from medications that would help keep them alive. Healthcare providers are the heroes that continue to show up, but they cannot and should not have to do so without the systemic change that is needed to empower communities to respond. We need to break down antiquated barriers to care that claim lives. We need to give communities every tool to tackle this crisis. We need methadone and opioid treatment programs and mobile clinics, and we need to pass the Modernizing Opioid Treatment Access Act and put methadone for opioid use disorder in pharmacies, prescribed by doctors who are board certified in addiction. And we need to get that bill passed this year so that people can just be guaranteed that their pharmacist can give them the help which they need and prescribed by a doctor who is board certified in addiction medicine. In short, we must treat this epidemic with the full force of our healthcare system, bridging every gap in every community to guarantee that every person gets the care they need when they need it. But this isn't a crisis without a cure, but the cure requires that we act urgently, pass smart, effective policy now. I went out on my first date with my wife 39 years ago, an Irish Catholic politician from Massachusetts, with a Jewish doctor who was the chief of behavioral medicine at the National Institute of Health. And I was trying to look smart while she explained to me that we were in a mental health and substance crisis in our country, and we had to destigmatize both mental health and substance disease in our country. And she had just been named the first head of Project Depression in our country. She was given the job as the chief of behavioral medicine to destigmatize. So, for 39 years at the kitchen table, I've got this lecture. I've got the lesson. You have to destigmatize, and you have to give people access to the help they need for diseases. It's not a character flaw. These are diseases, and people need to have access. And a disease without medication is just an hallucination if you think that's a cure, right? You need access to the medication. That's really what this bill is all about. I thank all of you for helping us to create the momentum that's going to make it possible for us to get this done, and for me to be able to tell my wife that I did get something done. But for 39 years, and with the help of the brilliant people in this room, we will see it done this year. Thank you, Paul Talbott.
That was terrific.
Dr. Chapman, you've been treating these folks for 40 years, more than 40 years. You witnessed firsthand the evolution of the drug trade in the U.S. from heroin in the 70s, crack cocaine in the 80s and 90s, prescription painkillers in the early aughts, to the influx of fentanyl today. Despite this evolution, the OTP system essentially operates the same way it did 50 years ago. Based on your many years of experience in the field, how do you think the current system can be changed to adequately address OUD, and particularly the threat of fentanyl?
Thank you so much for having me. I do want to correct one thing. I'm a 1973 graduate of Howard University College of Medicine, so I'm not the oldest practitioner. To give you an example, there are 4 doctors I'd like you to remember, 4 names. Dr. Vincent Dole, D-O-L-E, Dr. Marie Neiswanger, and 2 other doctors, Dr. Benny J. Prim, and Dr. Melissa Freeman. All of these doctors happen to practice in New York City. I met 2 of them, Dr. Prim and Dr. Freeman. Dr. Freeman was a 1955 graduate of Howard University College of Medicine. She retired, I think, last year. She ran a methadone clinic for all of those years, from 1965 until last year, if she retired. I don't want to put that on her, but and she was the first person to treat a woman, a pregnant woman, to term using methadone. So when I graduated from medical school, and I have to be honest with you, the last thing we wanted to see in the emergency room was somebody on methadone, because we only had about 2 hours training in mental health and substance abuse at that time. So much has changed. I practiced for 27 years until the year 2000, and I was asked by a friend of mine who was helping to reopen one of the methadone clinics here in the District of Columbia to be the medical director. And it changed my life. It changed my whole practice of medicine, my whole understanding of medicine. For the first time, I was treating people instead of diseases. So I no longer treat just high blood pressure or diabetes, I treat the whole person. And that came about because of really listening to the stories of the patients that came through, the trauma, not the physical trauma, but psychological and emotional trauma. So we're seeing that just recently through COVID, what happens when people are isolated, what happens when people lose their jobs, the trauma that people go through. Mental health problems went up tremendously during COVID, and we're still suffering from that. So part of that whole process, then after being in the methadone clinic for 12 years and struggling to really change that process so that we were not just treating the substance abuse, but that we were also treating the whole patient. I would get patients who came in and on their physical examination, one young man, I clearly remember feeling a mass in his abdomen, and he had colon cancer. So what we have to understand is that when patients are isolated and not in treatment, they also are not getting medical treatment as well. So what we found when we look back is that our patients live 20 to 25 years shorter lifespan. So I wanted to change that. And in 2005, I started using buprenorphine, which is one of the other three medications for substance abuse disorder. And in my office, I decided I wanted to create an integrated practice model. So that's what we're really talking about in this whole process, is really changing the way we treat people and to understanding the whole person. And understanding that whole person means that we also have to understand the socioeconomics that are involved, the trauma that is missed, is never talked about. So many people are growing up with what we call parabasic or adverse childhood experiences in adverse community environments. So we have to incorporate all of that in our work and our understanding. So I went back, I was invited back to Howard University Hospital in the Department of Behavioral Health and Psychiatry. And I said, I'm not a psychiatrist. The chair told me it doesn't matter. He was really on the same page. And we created this model using telehealth. I converted my office from paper records to electronic medical records and put telehealth in 2015. And that was 5 years before COVID hit. So we were prepared for COVID, not knowing what was coming. And at the current time, I treat 175 patients every month, coming to the office, and we're able to provide primary care services when they need it, as well as the addiction services using buprenorphine. So having methadone is a tremendous additional asset. And Dr. Benny J. Prim actually used that integrated model back in the 1970s, 1980s in New York City, seeing that people needed housing, employment, counseling, as well as reintegration into the community. So that's what we're really trying to do in this whole process, is to treat people the way we would want to be treated, and not have people on the street. I'm appalled around my office in new high-rise buildings going up, and tents in the median strip with trolley cars going both sides. And that was not removed until it snowed a couple of weeks ago. So we really have to understand that we can reduce crime, we can reduce tertiary diseases like AIDS and hepatitis C, but we have to treat the whole patient. So we're not talking about an individual approach, we're talking about a community-centric approach to care, which means this disease impacts all of us.
Dr. Olsen, SAMHSA recently published new regulations regarding the OTP system. Can you walk us through what the changes are, why the agency decided to make them, and what you hope to achieve?
Thank you. So this is something that, how many of you all have seen the updated Part 42 CFR Part 8 rule? Yeah. All right. Well, so for those of you who have not, so, as has been mentioned, the opioid treatment programs, they are where right now people can go and get methadone for their opioid use disorder, as well as a whole host of other services. The federal regulations that govern those opioid treatment programs sit in 42 CFR Part 8. Last week, SAMHSA released a revised version of the final rule of those rules, those regulations. They're really, for the first time in over 20 years, significantly and substantially revises those rules. And one of the things that we know, and as was mentioned earlier, that COVID really had a huge impact on this, not only the isolation and the anxiety that people felt, but also on the treatment system. Because all of a sudden now, really the drive was, we need to keep people safe, we need to keep people get them access to their medication, And we need to actually kind of have some separation, some distance between patients and providers, between providers and providers, right? So the shift really from what was a very outdated set of rules where people often did have to come in every day to get their medication. Now all of a sudden, SAMHSA and others at HHS and the DEA really expanded and said, no, we're not going to we're going to waive those regulations that require that people come in every day. And so we learned a lot over the last 3 years from that experience. We learned, and there's not only just anecdotal kind of clinical experience, but there's research to show that removing kind of that barrier of having to have people come in every day led to improved retention in treatment. It did not result in increases in methadone-related overdoses the way that there had been some concern about. And so SAMHSA really took to heart that evidence and that experience and included in this final rule the flexibilities such that people no longer have to come in every day. That they really can take doses home to take, at their as prescribed, but at their leisure, before they go to work, before they drop their kids off at school. So really enabling people to have that, live the lives that they want to live. So that's kind of number one. The second flexibility that also then was put into place under COVID was telehealth, and really making sure that now not only can people continue to get their medication, but also that people can start medication via telehealth. And that includes both buprenorphine in opioid treatment programs, and as well as outside, but that's a whole other that's the DEA, so we're not talking about that, we're really talking about SAMHSA's OTP regulations. So that flexibility of really being able to help people start buprenorphine in an opioid treatment program through telehealth, including audio only, has also proven to be safe and effective and has increased access. I think the battery is dead. So, all right, I'll be loud. Tell me if you can't hear me. So essentially, that is another flexibility that has been incorporated into the final rule. So people can then get started through telehealth for buprenorphine, also through audio only. We also really expanded that to include methadone. Now, methadone is slightly different, so really now through this final rule, people can get started on methadone through an audio-visual telehealth platform, which really then should be able to actually have people in mobile clinics, mobile medication units, be able to actually start people on methadone in places where that was much harder to do earlier. The other kind of key thing is that, and I'm not going to go through all the changes because there are a lot, but there are two other kind of key changes that I wanted to highlight. One is that prior to this final rule and under the old rules, you had to have at least 1 year of an opioid addiction in order to get access to treatment and access to methadone in an opioid treatment program. That, under the Consolidated Appropriations Act, Congress also required that SAMHSA remove that requirement. And it makes sense, because now in the era of fentanyl, there are people who may be using fentanyl, or who have had, they've been in remission and recovery for an opioid use disorder, but now are really scared that they're actually going to have a recurrence. So having them have the ability to access the services in an opioid treatment program, including methadone, makes a lot of sense. The last thing I wanted to mention is also that we have heard, over the past, and as Representative Taco mentioned, that people who have an opioid use disorder often encounter the criminal justice system, and often in jails. They're often kind of in and out of jails. And one of the things that the rule allows for now is for jails to be considered as kind of hospital/clinics at the state level. With that, there is a provision that really allows them to provide methadone to individuals who are then in the jail system outside of the framework of an OTP, as long as that opioid use disorder is kind of a secondary condition to a primary condition. What that means is that for people who are, for example, in taking methadone in the community and they happen to have an outstanding warrant for their arrest, they get picked up, they end up kind of in the jail system, they now can still continue to get their methadone in that jail without that jail having to become a full opioid treatment program. We anticipate that that's going to have a really huge impact across the country because, as you can imagine, there are jails that are like, why should I become kind of a full comprehensive OTP when, we have people cycling in and out and for very short stays. But like insulin, like other, really life-saving medications, that they want to be able to continue people on those medications and not have to completely just disrupt that person's treatment with then the potential for that person to then go out, use fentanyl and die upon release. So that's another kind of really key change that we anticipate will really have the potential to change kind of the face of methadone treatment in that carceral setting. So, so I think in the other kind of piece to this is that all of those changes were really made based on evidence, based on also 50 years of clinical practice and what we learned under the COVID pandemic. And what we've tried to do is to move this from a very rules and regimented, kind of very rigid framework to one that is person-centered, that is based on provider autonomy and clinical judgment, and really having that, having it move into kind of, this is medical care, right? And really having that, that culture and that culture of support and recovery, and really being able to help not only save lives, but have people have the chance at recovery with the services that they feel like are going to be the best for them. So that's kind of, I think, in a nutshell, but happy to also talk more later about some of these changes.
Thank you so much for those changes. I mean, we all know people who have, when the jails weren't allowing the treatment to continue, we know that when people get out of jail, they're 40 times more likely to overdose and die because they are opioid naive. So that's just a great gap to close. Zach, from the perspective of someone who runs an OTP, if methadone were to become available outside of OTPs, how would that impact you and your treatment setting?
We need help. We need help. So I don't know that there would be any impact on our treatment centers. A path like the MOTAA, the bipartisan bill that's been talked about today would offer, would allow us to, at a minimum, allow our stabilized patients that don't need or want the comprehensive array of services to be moved out of the OTP to free up those slots for people that have a higher severity of disease. So, I would say it would be, if you're looking on the business side of it, which we can't ignore in American healthcare, I don't understand why some of my OTP colleagues see this as a turf war, because the turf right now is so vast that we need help. And it's just, to say that board-certified addiction specialists who have the highest level of training in addiction in the country shouldn't be able to utilize these medications. If we said that about any other area of medicine, it would just, be like saying the oncologist shouldn't be able to order oncology, cancer treatments. It's crazy. And so I don't think that it would have any impact on our treatment centers other than allowing our treatment centers to get more people in that can't currently access care while giving other patients a choice of a different model or to receive treatment. And one thing I want to say on the recovering person side, that my last days in treatment, one of the biggest triggers one of the biggest potential barriers to the progress that I've made over all those years was that the one place I was not able to divorce myself from people who were using drugs chaotically was the OTP. So once a month, and I credit the OTP system with saving my life, but I should have had a choice where I did not end up in a dosing line or otherwise in a lobby with people who may have, and many were still actively and chaotically using drugs. It's not to say they didn't need to be there, because they did. They were in exactly the right place. And so when we have a system, though the good work it does, that can become a barrier to the people's long-term sustained recovery, we have to think about other pathways. But the treatment centers itself, I think it would just help us serve our community better.
Thank you. Dr. Olsen, in 2021, SAMHSA reported that 91% of Americans who needed treatment didn't receive it. Can you talk about some of the causes for that gap and what SAMHSA is doing to address it?
Yeah, thanks so much for that question. I think we talked a bit some about it, and Zach, I think you mentioned, that stigma that people experience, and really just this sense that, and this myth that, you're trading one drug for another, trading one addiction for another, those are the things, that's huge. I think the other piece is that, there certainly are access issues. That's some of what we've really tried to address also in the regulation. And there's also really lack of understanding among the healthcare professions. And so there are, behavioral health workforce kind of issues that also have played into some of this. What SAMHSA really has been trying to do, not only kind of through this regulatory change, but all of the services, all the grant funds that we get, is really promote comprehensive services for people who have behavioral health conditions, and provide training and technical assistance resources to make sure that healthcare practitioners, no matter where they are, whether they're working in primary care or in a specialty treatment setting or in a hospital or an emergency department, really also can talk about and talk knowledgeably about all the various different options that people may have for the treatment of their opioid use disorder. That also includes making sure that people, whether they walk into an emergency room or a primary care physician, can also be screened for the presence of an opioid use disorder, because sometimes it's hard to, for people who may think that they really, have a problem, but aren't quite sure, or just don't think that they actually really could benefit from care, having to have that diagnosis made can be challenging. I think the other piece that I would just highlight is that we certainly, and Representative Tomko also as mentioned the MAT Act, and we are so we really have been taking the implementation of the MAT as well as the MATE Act that passed last year, and trying to make sure that now healthcare practitioners know that they don't need a special waiver to prescribe buprenorphine to treat opioid use disorder, as well as making sure that all of those registrants, those DEA registrants, really understand that yes, there is a requirement that if they're going to now either newly apply for or renew their DEA registration to prescribe any control medication, that they need to have those hours of SUD training. Because even though Dr. Chapman said that, in the 1970s, that he got 2 hours of education on substance use and mental illness, I was in medical school in the 90s, and we got 2 hours. And last year I was in Missouri, and I talked to medical students there, and I asked them, how many hours of education are you getting? And they said 2 hours. So we really still have a long ways to go to make sure that people who are going into healthcare and being part of the healthcare system understand what substance use disorders are and what the treatments effective treatments and evidence-based treatments are as well, so.
Dr. Chapman, according to the CDC, in 2020, OD death rates from opioids increased 44% for Black Americans. This recent steep increase in OD deaths is largely driven by illicitly manufactured fentanyl and fentanyl analogs. However, it can also be attributed to the lack of treatment available in Black communities. CDC found that evidence of past substance use treatment was lowest for Black Americans, with just 8% of those who died from an overdose having engaged with substance use treatment. Dr. Chapman, you've dedicated your entire career to addressing these disparities and are a nationally recognized leader in this cause. What policy changes do you think need to happen to close the treatment gap?
So of course, we have to look at this first from a structural standpoint and historical racism. The fact that African Americans only account for 5.7% of physicians. So just from pure numbers, 6% of nurses, 5% of social workers, 4% of psychologists, 2% of psychiatrists. So we have a structural problem, a structural gap that has to be closed. That obviously means education. The other thing is that in our community, we're still suffering from the remnants of stigma. Many in our community still feel that substance abuse is a moral problem. So we have to educate the community. And the way we do that is working certainly through our community organizations, but particularly through the faith community. And SAMHSA has published whole documents showing the importance of the faith community in expanding this work. So we actually started an organization 11 years ago called the Leadership Council for Health Communities here in the District of Columbia, first addressing AIDS, but over time I was able to inform the pastors and others to talk about substance abuse because it wasn't something that they wanted to accept initially. Now we actually have a grant from the Department of Behavioral Health to help returning citizens who are incarcerated coming back into the community because it's common sense. You know that if you're in jail, you don't have a job. If you were homeless when you went in jail, you're going to be homeless when you come out. So again, when we talk about that community-centric approach, the idea that we as a community have to take responsibility and really understanding if you read Dr. Mate and his approach to the way communities react, that we create the problem, so we should solve the problem. We can't escape the fact that we are also part of the problem. Our economic system is part of the underlying cause. So we have to deal with that in a holistic way, public policy as well as education. And of course, finally, just in terms of access, we know that there are pharmacies in our community, not just this community, but all around. Pharmacists, we don't want those kind of patients in here, or we don't get paid. We're not getting reimbursed for buprenorphine or our medications. So we are working on a provider pharmacy peer collaboration in the district, which will educate pharmacists, but also assign patients, particularly to a peer support system that will help walk them through this whole process. So when they come out of incarceration, they're not just, the door is not just open and they're let out with no direction. We're going to take them by the hand from the time they come out. And we think that creating this model and reintroducing patients not only to housing but also to employment opportunities, that we can reduce the recidivism rate.
Thank you. Dr. Potee, one critical intervention point is during incarceration. Studies found that a person released from incarceration is as much as 120 times more likely to die of an overdose following release. However, the risk of fatal overdose drops by as much as 80% if inmates are provided MOUD during incarceration. Just as a side note, I have a chapter about what they've done at the Fairfax County Jail, where they have co-located counselors in the jail. Everybody's screened, everybody's offered MAT, and most importantly, they're assigned a peer to come up with that plan for that critical exit point, and a warm handoff so that they have Narcan and an appointment to get their MAT when they leave. Dr. Potee, as medical director of the Franklin County House of Corrections, what challenges did you face in bringing methadone treatment to patients at the facility?
Well, if every place looked like Fairfax, we'd be in great shape, right? So I'm gonna just backtrack for a minute and just thank SAMHSA and thank Dr. Olsen for the changes that were made, because I was fired up last week. I knew what had been proposed, and there were actually surprises, things that were even better than I expected in the changes, which was great. And the fact that they threw in correctional facilities that could look like hospitals has the potential to be a game changer. And yet, it still may not work. So I want everybody in this room, I see a lot of young people taking good notes because you guys are gonna write up a paper, it's awesome. I need you to go back, I need you to go to the SAMHSA OTP locator for your state, and I want you to look where your methadone clinics are. I want you to look, and I want you to be careful when you look, because anybody, a detox in a jail, will be licensed as an OTP, but they don't give out methadone to the community. So you need to only look at community-facing OTPs in your state. I want you to stare at your state map and ask yourself, could I get to that place every single day? Could I do it? And I know your answer is gonna be no. Because I'm in Massachusetts, and then we have Rep. Tonka from New York, and then we have Rep. Norcross from New Jersey. Per capita, we have more OTPs than I think any other state, the three of us, Massachusetts, New York, New Jersey, and the entire country. And I'm telling you, in Massachusetts, people can't get to their methadone clinics every day. It's a tiny state. So MODA needs to pass because most of us have a community pharmacy everywhere. I'm a family doctor. I do everything. I do joint injections, IUD insertions, deliver babies, take care of kids. I do everything. And every primary care doctor out there has the capacity to take care of people with addiction, period. We just do. We are used to doing all chronic diseases. It's not unusual. Becoming a methadone clinic at my county jail was the hardest thing I've ever done in my life. I've run multiple marathons. I used to work as a resident before there was work hour reform, which meant we worked 80 to 120 hours a week. I've had 3 natural childbirths. Hardest thing I've ever done was to become a methadone clinic, which is ridiculous, right? Because the amount of work it took, the paperwork, the calling the DEA, everybody was like, we don't know who you are, we don't know why you would want this. This was in 2018. And I had a sheriff who was committed to public health and who said the right thing to do is to take care of people who have addiction in our facility, because 80% of people walking into a jail have addiction. So how could you not take care of it? So it's a hard process to become your own OTP. The new SAMHSA regs could make it easier, except the DEA is going to be a problem. It's going to be a big problem. And MODA will solve this. If MODA passes, any board-certified addiction doctor could prescribe to the jail from any pharmacy without the DEA having oversight. And the final thing I'm going to say on this is that when you have your little person started on methadone, stable, better, healthier while they're at jail, and then they get released back to their home county, the 80% of counties that don't have a methadone clinic, without MODA in place, how are they going to continue their treatment? It's going to fail. So, again, we've had our methadone license at our county jail for 5 years. We've trained the Federal Bureau of Prisons. We've trained both state DOCs, and this is in a tiny town of Greenfield, Massachusetts, with a population of 15,000. And the federal BOP is the largest OTP in the country right now because the feds are on top of it. But I want you to go back and look at your state, because I guarantee you, your counties and your DOC are not able to do their jobs. It's too hard.
Amen. When, I don't know how many of you have seen Dopesick, the show, but when the show was greenlit, I said to the showrunner, I have 2 goals. I want you not to stereotype Appalachia, which always happens. And two, I want a really clear storyline about access to MAT. And so you have an A-list actor like Michael Keaton driving himself and his friends 2 hours one way on rural Lee County, Virginia, to a clinic in a city. It's just ridiculous. And we know that our jails, that's a critical intervention point. But I just want to open it up to questions now. It is so amazing to have this level, next level, cutting edge level of folks here. So, yes.
Thank you so much for doing this. I'm Carmen Bond, I'm a health reporter at Politico. So I have heard a lot of things from OTPs who do oppose MOTA, and I wanted to ask if you could address some of their arguments. One of them, and you know probably better than me, the campaign called the program not a pill. So one of their arguments is that just giving someone a pill, in this case Methadone, is not going to be enough for them to help them recover. That they need behavioral interventions, they need support more than just a pill. And if they just get it from a doctor, get it from a pharmacy, they're outside of that system. So I wanted to ask you if you can address that, and how big of a problem that is, or if that's a misrepresentation.
Okay, I'm gonna go first, and then Zach's gonna go second, and then maybe Dr. Olsen will go third on this one. I said, one of my answers is gonna be follow the money, right? Counseling is one of the few things that's billable in a methadone clinic, depending on the state and the insurer. So if a patient needs therapy, needs counseling, needs case management, they should absolutely have access to it. But if they don't, they should not be forced to do it. And the problem with methadone clinics is they actually, I mean, you guys know this because you're all wicked smart, but what are the treatments for depression and anxiety? The best treatment is therapy. Second best, probably exercise and mindfulness work. Those are the three things. What do we really do? We hand you a prescription. If we don't mandate you go to therapy and you do 30 minutes of exercise and you start meditating, although you can imagine a world where that is mandated. That's what methadone clinics do, right? The medicine works. It works alone. The studies show that. And for people who need additional therapy, they need access to it, and it should be part of the program. But mandating it, and for those of you who don't know what clinics look like, Zach was being really kind. There are great clinics out there. But I would actually argue the majority of them do not practice evidence-based medicine. They're carceral, right? They control your life. You might stand outside in that terrible snowstorm in New Jersey for 2 hours waiting for your medicine. How do you take care of your kids and go to work when you're doing that? And you don't get a dose increase until you see your counselor, which is 2 weeks from now, right? That's not evidence-based medicine. So when the industry comes to you and says MOTA is going to cause harm to patients, I want you to ask them, show me your backers. Are you guys a for-profit owned by a private equity company? And if the answer is yes, then take a breath and talk to people where the money doesn't drive them.
Amen. As we say in the South. No, I mean, those are all extremely valid points, but also any program on appeal or any other compilation or consortium of folks that claim that what they have is the best interest of patients at heart, that they are not patients, you should be very skeptical of. Because, I mean, if anybody should be defending the system on a turf war, it's the guy who's built his entire career and put his entire life savings and blood, sweat, tears into opening OTPs. But because I was a patient at one for 10 years and because I'm a recovering person, I also, and because I understand that there's such a crisis right now, it's not gonna make me homeless, patients have to come first. But the people, if they're not patients or not patient advocates, be skeptical first and find out who their backers are. Who's really at the top of that company? Is it the president and CEO? Or is there another layer? Or are there shareholders? And, so you have to find out what's driving it. And it seems silly to me because there's not a business threat, but when you have people in many chains, I'm not talking about any in particular, that make decisions based on spreadsheets and don't have operational, administrative, much less clinical knowledge when it comes to operating programs and/or dealing with the complex realities of the chronic disease of opioid use disorder. You're going to have little cutesy campaigns pop up to try to quash legislation that from the beginning has been backed by patient advocates that have operated OTPs, have been involved in drafting that bill from its very first iteration, before it was the MOTAA, and it was the OTAA. And so, that's a turf war. And it's a turf war that doesn't need to exist, because the OTP system, when it's done right, is a service to a community if there's not enough of them, and patients also should be able to have treatment outside of that when it's clinically indicated.
We have time for one more question?
Can I ask?
Sir?
I'm sorry, I probably shouldn't ask, but I'm going to ask anyway. Can he get the microphone? Sorry.
Yeah.
Okay. Sorry, I shouldn't ask, but I just want to ask anyway. Zach, you described a person who had a master's degree and also having disease of addiction. I think someone else described a person as accidentally acquiring the disease of addiction. And someone else described the person as a different type of person. And then there's the person who lives under the bridge and looks like me. Should it matter the type of approach that we take, or should it matter how that person acquired the disease as to what type of intervention that we should take to resolve the symptoms?
Yeah, that's me. I think that it's, I could have been the person under the bridge if I didn't have access to the services that I had. But there's also a certain amount of privilege and resources that my family had, that I had the gas and the tires to go 2 hours in each direction. And so we have to certainly consider those realities as well. But I think the chaos of active opioid use disorder, just like most other substance use disorders, will ultimately lead to those realities, to a complete destabling of one's life. It's some people, based on resources and privilege, I would say, have further to, may take longer to get there. Not that that's right. I think that's a reality that's got to be in the overall conversation.
I'm so glad you asked that question. I'm going to send you a video that PBS NewsHour did and went nationwide on December the 8th that actually showed one of my patients who lives under the bridge in the District of Columbia. Comes to my office once a month to get buprenorphine, and he still lives under the bridge, even though everybody in the government saw that. So housing is medicine. 80% of health outcomes are related to things that happen outside of the doctor's office and hospital. So this community-centric approach is what I was talking about. Our responsibility as a community. Where are the churches? Why are they not marching in front of City Hall? We have people protesting because the wizards and the cats are moving out of town, but they're losing records, but nobody's talking about the homeless in the median strip in front of my office.
Thanks, everybody, so much for coming, and thanks to the panel.